Smith, everyone. I'm a physical therapist down in the downtown Kirkland clinic. I am really excited today to welcome Dr. Lauren Vernese to join us on our webinar today. She's going to be telling us all about sacroiliac joint disorders, treatment, diagnosing. So we're really excited to have her here. She's based out of Swedish. She works both in Bellevue and downtown Seattle. So thank you so much for joining us, Dr. Vernese.
Awesome. Thank you, Kerri. Nice to meet everyone virtually. So I'm going to be talking on sacroiliac joint pain and dysfunction. And the reason why I chose this topic is it's actually quite prevalent in my practice. I do a lot of manual therapy in addition to spine and sports management. So I often see people with complex low back pain. And I find it despite seeing it so often, it's different in every patient. So the diagnosis and the treatment can be quite complex and very tailored to each person. So I'm going to go ahead and get started, and that you can also comment on any questions down the bottom, and hopefully we'll get to them at the end. Okay. So I have nothing to disclose. Here's a brief overview of what we're going to be talking about today. And again, hopefully we'll have time at the end to do a little discussion. Our objectives today, first, are going to be to understand the SI joint pain or structure and to understand possible SI joint structures that can cause the pain. Also to improve confidence in the ability to make a diagnosis of SI joint pain, learn what evidence exists for treating SI joint pain as well. So I know a lot of you out there are physical therapists or physicians, so I'm probably preaching to the choir when I talk about the prevalence of low back pain, but it is extremely common in my practice, and it's one of my main reasons for referring patients to physical therapy. Although it's more common as we age, it affects people of all ages. I actually have in my practice a lot of teenagers and people in their early 20s already developing chronic low back pain. The lifetime prevalence of low back pain, typically considered non-specific low back pain, is estimated to be around 60 to 70%, and of any back pain is around 85%. And as a leading cause of activity limitations and work absence, it imposes a very high economic burden on individuals, family, and the workforce. Despite being so prevalent, we still really don't understand how to treat it, and also a lot of the diagnostic workup that we do for it sometimes still doesn't give us an exact clear picture. So there are many different pain generators for causing low back pain. Again, this is more looking at sort of a chronic picture, typically described as more than 3 to 6 months of low back pain. I typically, when I'm looking at a patient with low back pain, I'm thinking of what structures are under my hands, what am I palpating? So starting with the skin, then the fascia, connective tissue, muscles, ligaments, the bones, the discs. Then I also think of other biomechanical issues that might be contributing and psychosocial factors contributing. And then I also look at other areas that might refer pain to the back. There are consistently 3 documented causes of low back pain in the chronic category. That includes lumbar discs, lumbar facet joints, and also the sacroiliac joint. And these are based off of diagnostic tests that can sort of prove the etiology rather than more referred pain. It's sometimes hard to actually prove that. When looking at the frequency of low back pain generators, the disc seems to be the most common. About 40% of cases of low back pain can be attributed to the disc. The facet joint is about 10 to 40%, with higher percentages in patients that are older. Sacroiliac joint pain is typically the cause in about 20% of patients. However, as this number gets higher after people have had lumbar fusion or lumbosacral fusion, and we'll get into reasons as to why that's the case. So I like to always talk about history before I go into any topic. I actually had never looked into this before, so it was interesting to prepare for the lecture to look that back in the early 1900s, the sacroiliac joint was actually considered one of the main pain etiologies and contribution to low back pain. There was actually a surgery done in 1926, documented as the first SI joint surgery to try to alleviate these pain. Unfortunately, then in the 1930s, 2 surgeons performed their first discectomy for disc herniation causing nerve root impingement. And then they came out with a paper in 1934, basically saying that almost all low back pain can be contributed to the disc. This then put the SI joint in the back burner. However, around 1956, the first fluoroscopic guided SI joint procedure was performed that actually was a provocative procedure, proving that provocation of pain in the SI joint reproduced the patient's symptoms. So again, the SI joint was then considered a possible pain generator for low back pain. Then over the last 30 years, there have been different surgical techniques that have come out to try to work on fusion of the sacroiliac joint. As we'll get into, the etiology of it is often thought hypermobility. Unfortunately, these initially had very limited success, typically around only 50%. However, more recently, the iFuse system, which we'll very briefly go over, seems to have more about 88% success. I'll go over my concerns about sacroiliac joint fusion, but that is what the literature is currently showing. So the sacroiliac joint is considered a diarthrodial joint. This is made up of the sacrum, which is 5 fused segments of the spine, and also the ilium bone, which is part of the pelvis. There's a thin layer of cartilage that lines the joint, and there is a joint capsule and a synovial membrane surrounding this. The synovial membrane itself produces a small amount of synovial fluid to lubricate the joint. And it's thought that this joint is about 2 milliliters in size, so a very small joint compared to other joints that we think of in the body. The posterior aspect of it is more fibrous and made of ligaments and different fibers to help give further stability. The sacroiliac joint itself changes between individuals in terms of its shape, size, and contour, and also as a person ages. So typically beginning around birth and through about age 10, the joint begins to enlarge and the anterior capsule begins to thicken. The joint is actually relatively flat and smooth initially, but then as one ages, you start to get bony contours and ridges within the joint, and this gives more stability to the joint. However, typically around the 5th or 6th decade, people will start getting bony osteophytes within the joint, which can contribute to pain and actually be painful as well. These will typically first occur on the ilial side as there is less cartilage on this area. And so the function of this, we're going to go into a little bit more detail, but basically it connects the spine to the pelvis to provide load transfer and stability. And I'm an osteopath, as I've said, and so one of our tenets is considered structure and function are reciprocally interrelated. There's no better example than in the sacroiliac joint. And what I mean by this is that the design of the joint itself tends to give the function. So what you can see here in this picture is showing the rough bony contour of the sacroiliac joint. And so the sacrum is actually wedged between the ilium, providing what is called a form closure. And then it's surrounded by many different ligaments, most important of which are the posterior ligaments of the sacroiliac joint. So there's the posterior sacroiliac ligament. And this is typically what we're palpating when we're looking for SI joint tenderness. And then more important actually is the interosseous sacroiliac ligament. This is the strongest ligament given its extensive bony coverage on the sacrum and the ilium. And actually cadaver studies have shown that a tear in this, or if you cut it, will lead to SI joint hypermobility. So this is likely a culprit when some patients have asymmetric hypermobility in the sacroiliac joint. Then anteriorly is the anterior sacroiliac ligament. And this is much thinner than the posterior structures and can actually cause some tearing and leakage of the synovial fluid, which can irritate nearby structures. Very important to give what is called force closure to the sacroiliac joint are surrounding muscles. And some of these are the largest and the strongest muscles in the body. So one of the most important muscles is the gluteus medius, or it's gluteus maximus muscles, which is pictured here on the left. There's also the erector spinae muscles and the latissimus dorsi muscle, which is not pictured, but it blends into what's called the thoracolumbar fascia. These muscles all blend into the different ligaments of the sacroiliac joint. So an imbalance in any of these muscles can pull on the ligaments in an abnormal pattern and contribute to SI joint pain. One of my favorite muscles is called the gluteus medius muscle, which is pictured here over on the right side of the screen. And this gluteus medius muscle provides lumbopelvic stability and single leg stance. So any imbalance in this muscle can contribute to an abnormal mechanics in the sacroiliac joint. All the other hip stabilizing muscles are also very important to providing stability to the sacroiliac joint. Deep to these muscles is the pelvic floor. This is actually a key component in people, especially postpartum women, and then also more general women rather than men as they age. However, I have seen many pelvic floor dysfunctions in men. But what will happen is these muscles can become either weak and overstretched, or they can become really tight or hypertonic and contribute to an imbalance in how the sacrum and the sacroiliac joints function. So there's many different motions of the sacroiliac joint. The main ones that we look at are called nutation and counternutation. Nutation is when the superior aspect of the sacrum flexes forward, sort of going like this, and the bottom part goes posteriorly. And this is also known as lumbosacral extension. So you'll see the spine, maybe someone with more of an anterior pelvic tilt will have this. And then there's counternutation where the top of the sacrum actually goes posteriorly, and someone will have more of like a flat back appearance with this, and that's also called posterior pelvic tilt. So sometimes the sacrum gets stuck too far forward or stuck too far posteriorly, and this can contribute to symptoms. Another motion is called rotation. So that's or torsion, where the sacrum is actually moving like this. So I sort of think about someone walking, and the sacrum actually rotates on two different axes called a left on left oblique axis pictured here in the bottom, or right on right oblique axis. What's important about this is that when we walk, we actually, if we put our foot down and heel strike on the right, you're going to form a left on left axis and vice versa. And what happens is some people will get stuck in an abnormal pattern where when they put their right foot down, they actually go posterior, or that sacrum is actually just stuck posteriorly. Then you can't have normal gait mechanics. And so these people will often have pain with walking, running, bending, lifting, different exercises, just because the sacrum is actually stuck in a weird position. Additionally, the ilium itself could be stuck. So we call that more of an iliosacral dysfunction rather than a sacroiliac dysfunction. There's also a motion called translation, which is really just any motion in a single plane. So the sacrum going up or down or sideways, so compression, distraction. There are a few other motions, but those are the key ones that I like to look at. So the sacroiliac joint function, again, I just briefly had touched on this, but the main idea is that it's supposed to be a load transfer from the lower extremities up to the spine and from the spine down to the lower extremities. If you didn't have the sacroiliac joints, which again, load transfer can be considered sort of shock absorption, then all of the forces might be targeted to one level, and it's predicted that this would be at the L5-S1 level. So if you have restriction in the sacroiliac joints, you might have more accelerated arthritis at the L5-S1 level because all of the forces from the lower extremities with each step or running, walking, jumping might be forced into that L5-S1 level. It also provides stability through those muscles that we talked about in the ligaments to the hip, and can contribute to gait issues, as we were talking about. If you have an abnormal rotation of the sacrum, it can cause gait abnormalities. So unfortunately, despite having known about the sacroiliac joint as a main pain generator since the early 1900s, we still don't have a great understanding of its innervation, which would be helpful for doing procedures that we'll talk about later called ablations to block the nerve signals. In general, it is based on cadaver studies, we think that posteriorly it's innervated by the dorsal rami of L4 to S3, with S1 and S2 being the most important. Anteriorly, the upper portion is innervated by L5 ventral ramus, and the lower portion is by the ventral ramus of S2. The synovial joint itself is thought to be innervated by the dorsal rami of S1 to S3, with again S1 and S2 being the most important. So typically when interventional spine doctors are doing procedures, they're focusing on multiple different levels. But again, we don't really know the exact innervation pattern, and that's likely because it's different from patient to patient based on different cadaver studies. So now what actually causes SI joint pain? I sort of have alluded throughout the lecture already to different things that could be contributing. Unfortunately, one of the main causes is known as idiopathic, meaning we just really don't understand what's causing it. Another main cause of sacroiliac joint pain, typically more acute, is going to be traumatic. So often I'll have someone coming in after a direct fall into the buttock, and at that point I'm trying to assess, did they actually just bruise their sacrum, do they have a fracture, or do they have now a sacroiliac joint dysfunction that's causing their pain? Sometimes lifting can contribute to the sacroiliac joint getting stuck in a non-physiologic or an abnormal pattern that can cause pain. Sometimes missing a step, so if you go to take a step and then suddenly you jam your leg, that can cause a shear on the sacroiliac joint and either tear the ligaments or cause the sacroiliac joint to get stuck. Also, motor vehicle accidents can be a contributing factor. I've had patients where their right foot was on the gas pedal when they were either rear-ended or hit another car in front of them, and then their sacroiliac joint gets jammed on that side. Looking at more atraumatic causes, so these are broken down into two categories. So even though it's atraumatic, cumulative repetitive microtraumas can contribute rather than one big injury like a fall. And another is inflammatory. So really anything biomechanically that can affect the thoracolumbar spine, whether it's structural or an imbalance in muscle, tendon, fascial connections, can affect the sacroiliac joint. Studies have shown that patients with scoliosis have a higher prevalence of having low back pain. They're not strong studies, but they have been suggested. I did look into a study about specifically sacroiliac joint dysfunction and scoliosis. I only found a few. One was a study actually in 196 adolescent athletes that demonstrated that patients with idiopathic scoliosis tended to have a higher incidence of sacroiliac joint dysfunction. They didn't necessarily comment on pain, but they were talking about abnormal mechanics in the sacroiliac joint. Also looking at leg length discrepancy, this is likely contributing to the cumulative repetitive microtrauma from abnormal mechanics and forces going through an asymmetric load of the facet joint during the gait cycle. And then lumbar or lumbosacral fusion is a very well-known cause of sacroiliac joint pain. This is because when you fuse the lumbar or the lumbosacral spine, now you've changed the forces through the sacroiliac joint. And so again, I noted before the prevalence of sacroiliac joint pain is a contribution to low back pain. This number can go up to about 40, 42%, versus patients who have not had a fusion, it's typically cited around 22%. Then pregnancy is a very known cause of low back pain and sacroiliac joint pain. Probably most pregnant women who are going to a physical therapist are going because of this issue. And it's typically because hormones are released in the body that are preparing the pelvis for delivery of the baby. And so you're releasing relaxin and estrogen in the body that can cause some ligament dyslaxity. I tend to see patients who have more low back pain during pregnancy, people who are already hypermobile, meaning their ligaments were already a little bit more on the loose end, and then now they have these hormones in their body. And so it's causing increased stressors across these ligaments and across the joint because the ligaments aren't necessarily doing their function that they should be. Additionally, just to further support this, there have been some studies showing that non-pregnant women who have higher levels of relaxin in their body do tend to have more sacroiliac joint dysfunction or pain. Another thing to look at with pregnancy is the increased pressure from the load from the fetus pushing down onto the pelvis can also change the mechanics and the structure of the sacroiliac joint itself, changing that force closure. And then another thing is going to be inflammatory arthritis. So the main thing we think about is ankylosing spondylitis. This is an inflammatory condition typically thought of in young male adults where they start to get fusion of their sacroiliac joints. And then it slowly progresses up their lumbar spine and sometimes even to the thoracic spine. This is typically going to be, again, in young males. However, more frequently, I've been seeing this in females as well. And this can be a big source of sacroiliac joint pain because you actually develop more hypomobility, so lack of movement of the sacroiliac joint, which causes a lot of low back pain and stiffness. Eventually, as they fuse, they tend to have less pain and stiffness in that area, and the pain goes up higher in the spine. Osteoarthritis is another known cause. Again, as I said earlier, around the 5th and 6th decade, people will tend to get osteophytes in their sacroiliac joints. These aren't necessarily painful. However, if you have repetitive trauma to this area or an imbalance in muscle tension holding the pelvis into a stable position, you can get bony edema, inflammation within this synovial fluid or tissues. Sometimes you can actually get little tears in the capsule itself, and the synovial fluid, which has pro-inflammatory mediators, can leak out. And you've got a lot of lumbar and sacral nerves passing through this area. So studies have actually shown that the L5 or S1 nerve can be irritated from this. Okay, so now on to making a diagnosis. Again, as I said earlier, it can still be very challenging despite me seeing many patients with this. Often when you're seeing patients with low back pain, it can be from any cause, and it's often multifactorial, meaning it's from multiple causes. I typically, whenever I'm making a diagnosis, like to look at history, physical exam, and also imaging. Unfortunately, when it comes to the sacroiliac joint, these are not very helpful. Each one alone is not helpful, but putting them all together might start to paint a picture of sacroiliac joint. However, fortunately, we have diagnostic tests such as diagnostic injections into the sacroiliac joint, and I tend to use these a lot. Again, my practice, I do a lot of injections. However, I'm more on the conservative side, and I tend to use them more for diagnostic purposes to confirm a suspicion of a diagnosis that might not be so clear through the other things, such as history, physical exam, and imaging. So I would like to present just a short case just to help get a better picture, the whole picture of who might be presenting to your office, who you might want to think about has sacroiliac joint pain. So here I have a 34-year-old female, former professional ballerina and mother of 2, with 3 years of variable low back pain. She's presenting to your clinic. Pain is located in her left greater than her right buttocks and low back. Pain is described as deep achy pain and sometimes sharp stabbing. This can radiate into the buttocks, down the lateral and posterior thigh, and sometimes into the posterior lateral lower leg. She has occasional numbness in her left posterior calf, but not into her foot. She also reports occasional stress urinary incontinence. Symptoms seem to be worse after standing from prolonged sitting and other transitional movements, and also with prolonged standing. She says symptoms are better with cracking her back. So this is a very typical patient I might see in my practice that I am now thinking this is more sacroiliac joint rather than maybe a lumbar facet or a disc herniation. So what components am I looking for when I'm taking the history? So first I'm starting with their pertinent medical history, especially with low back pain. So I'm looking for something such as spondyloarthropathy, which we were talking about, the ankylosing spondylitis. So does the patient have a history of chronic low back stiffness that lasts for more than 30 minutes in the morning? Usually I'm looking for at least 60 minutes in the morning. Also, do they have a family history of different rheumatologic conditions that might predispose them to having this? I'm also taking a history of, do they have arthritis, which could be contributing to hypomobility, or patients might say, I've always just had a really stiff low back. Then I'm also looking for someone with hypermobility. So someone who's currently pregnant or recently pregnant. I'm also looking for a history of, were they a gymnast? Are they really good at yoga? Not just doing yoga, but really, really good and can get into all sorts of positions. And then do they have a history of dislocation in other joints? Because I might be thinking they have then something called benign hypermobility syndrome. Next is the location. So most people will say if the pain is below the L5 level, you're thinking sacroiliac joint pain. If it's above the L5 level, you're thinking more the lumbar spine. This is blurred, as you can see. 72% of people with sacroiliac joint pain confirmed on diagnostic tests reported low back pain, and then 94% report buttock pain. Additionally, 14% will report groin pain, so that you might be then thinking, is this a hip issue or is this a spine issue? 50% of patients will report lower extremity pain, with about 28% reporting it past the knee. I was actually always trained that anything past the knee is going to be from the lumbar spine, meaning a radiculopathy or a pinched nerve in the back. However, I've more and more consistently seen people with sacroiliac joint pain confirmed on diagnostic injection with resolution of their symptoms below the leg, below the knee. Also, about 14% of the patients will have pain into the foot. Pain characterization can be very variable. And again, this is where it's not very helpful, but I do tend to listen for things like it's sharp, occasionally stabbing. There's maybe this constant dull, achy pain when I'm doing something for a while, like sitting or standing, and then sometimes numbness. If someone's saying something more like burning, then I'm actually thinking it's more of a nerve impingement rather than the sacroiliac joint. Some associated factors are typically urinary frequency or urinary stress or urge incontinence. This might be because of an imbalance in the pelvic floor muscles, low tone in the pelvic floor, or it could be just irritation of the sacral nerves, which go to the bladder. Exacerbating factors are also really helpful. Most commonly, they're going to complain about pain with transitional movements. So that's getting up from a chair, getting out of bed. Also, usually prolonged activities such as prolonged sitting, prolonged standing, prolonged walking. Again, those patients, I'm thinking they have more of a sacroiliac joint dysfunction, where I was talking about the sacrum getting stuck in a non-physiologic position. They may also have pain with unilateral weight bearing or stairs, and then also possibly pain with bending forward. I don't have up here alleviating factors because they've unfortunately not proven in the literature to have any consistent pattern. However, I will hear patients say cracking my back helps, or shifting my weight when I'm sitting to the asymptomatic side. So for the examination, we're going to go over a couple of things that unfortunately you have to combine everything. There's not one test that's really great for diagnosing SI joint dysfunction. And I do want to note that before my exam even starts, I actually examine them when I walk in the room. When I open the door, I'm looking at, are they grimacing how they're sitting? Are they shifting their weight constantly? So really my exam starts from the second I see the patient. Then after I've had their history and history, I stand them up to do a physical. I always start with them actually facing away from me while they're standing, and I ask, point to where your pain's the worst. If they point to the posterior sacroiliac spine, that bump on your low back, and they point to this area, this is considered a positive Fortin finger test. And this is considered to be somewhat sensitive and specific for sacroiliac joint pain, but not great because also the L5-S1 facet is in that region. Typically, they should be pointing inferior and medially to this area because that is typically where the joint itself is, but there's also the ligaments, as we looked at, that really extend all the way down along the buttocks, the medial aspect of the buttocks. Tenderness over that posterior sacroiliac ligament has a high sensitivity of 89%. I did not actually see the specificity, but I would say it's quite low because a lot of people will just have myofascial pain in this region. So again, performing different provocative tests, you want to combine multiple ones of these to have a better sense of what is actually contributing to the symptoms. So I've listed out here a bunch of different tests that you can perform in the exam room to look for sacroiliac joint pain. I'm going to go over just a few of them that I found to be more sensitive and specific. So the thigh thrust test, this is just demonstrated in this picture here. The patient is lying supine. The examiner is putting a force directly through the knee, through the femur to the sacroiliac joint. Reproduction of pain is considered a positive test. Patrick's or Faber's test, the patient is lying supine again. The examiner brings the hip into flexion, abduction, and external rotation while supporting the other anterior sacroiliac spine to stabilize the pelvis. The examiner then pushes down on the knee on the symptomatic side, and you're looking for pain in the buttock. If you have pain in the groin, this is actually positive for hip pathology, not sacroiliac pathology. So I always tell the patient to say, where does it hurt when it hurts? Next is going to be Gaines lens. So this is another test performed supine. The patient is towards the edge of the table with the symptomatic side leg hanging off the table. The examiner places the asymptomatic hip into flexion. The patient then holds on to that, while the examiner then brings the symptomatic side into more extension. Reproduction of pain in the buttock is going to be considered a positive test. I've actually seen sometimes where I tested in the opposite manner, where the asymptomatic side is extended, and that will sometimes reproduce pain. And I think it's more dependent on, is it the ligament causing the pain or the sacroiliac joint itself causing the pain? One of the most sensitive, specific tests for the sacroiliac joint is going to be distraction test. And this is where the patient is lying supine again. The examiner is pushing through the sacroiliac joints, through the pelvis to gap, or the other name is gapping test, to gap the sacroiliac joint. And reproduction of pain here is considered positive for sacroiliac joint dysfunction or pain. And again, this is more thought of a ligamentous etiology because you're actually opening up the joint. So if it was from arthritis, this would actually possibly alleviate symptoms. And then the last one we're just going to go over here is the sacral thrust. This is actually just where the patient is prone on their belly and you're putting direct force through the sacrum, and reproduction of pain is considered positive. There's all these other tests here called the Yeomans, Gillette or Stork test, and the sitting and standing flexion test that I also tend to use. However, in the literature, they're not as well studied. So in addition to these provocative tests, I'm also doing an exam looking for possible contributing factors such as those biomechanical structural abnormalities. So I'm looking for a leg length discrepancy, possible twist in the pelvis, where the pelvic bones can be rotated forward on another. I'm also looking in the lumbar spine to see if there's restriction of motion or rotation in the lower lumbar segments. Then I'm looking at the SI joints to see if they're hypermobility or hypomobility. I tend to see more patients with SI joint pain from hypermobility. And then I'm also doing an assessment called Beighton criteria, looking for benign hypermobility syndrome. Pretty much any patient I have with SI joint pain, I'm doing this test to basically say, do they have generalized ligamentous laxity? Because it's going to actually change my treatment approach usually. And then anytime I'm examining any joint, whether it's in the arm or the leg or the back, always looking one region above and one region below. So here, just in the interest of time, I'm not going to go over it, but this is for your review later. This is my standard approach to seeing a patient with low back pain. And I pretty much go through the exact same test every single time so I don't miss something. And also, as we said, the diagnosis is quite complex for sacroiliac joint pain. So really trying to do as many tests as you can to say, okay, I'm more certain that this is sacroiliac joint rather than lumbar facet mediated pain. So next are imaging and labs. Unfortunately, as I said, imaging does not really help in securing a diagnosis of sacroiliac joint pain. However, it can be used if your diagnosis is unclear and you want to say, does this patient have really bad L5-S1 facet arthritis or an inflammation? So I might be getting a lumbar spine x-ray and or MRI. I also might be looking at the hip, say this patient also has groin pain. Remember, 14% of patients with sacroiliac joint dysfunction and pain can have groin pain. So sometimes I'm also looking at the hips. Then also you might be looking at pelvis for sacroiliitis or osteoarthritis. So in a patient who I'm concerned about, say that young male who has low back pain and morning stiffness, and I'm concerned about ankylosing spondylitis, I'm going to start with x-rays of the pelvis. And then sometimes I get an MRI. I typically don't order bone scans. Usually an MRI is sufficient enough to show early inflammation in the sacroiliac joints. Next, I might be ordering labs. I'm ordering these really only on patients that I'm concerned for the ankylosing spondylitis or other forms of spondyloarthropathy, such as psoriatic arthritis, reactive arthritis. I'm going to order a general room panel, but specifically I'm looking for the positive HLA-B27, as this is positive in about 90% of patients with ankylosing spondylitis. It can be positive, though, without the diagnosis of ankylosing spondylitis, but it does make you think more highly of this being the cause if you're imaging and that labs fit. So now, how do we really diagnose SI joint dysfunction? Typically, we're doing a sacroiliac joint injection using an anesthetic such as lidocaine or ropivacaine. I personally am doing these in my clinic under ultrasound guidance, which is demonstrated here. So the patient is just lying prone on the table. It's a fairly quick procedure. I just inject into the sacroiliac joint a little bit of anesthetic, and then I have them keep a pain diary for about 6-8 hours afterwards, telling me how much did your pain improve. Most people are looking for about a 75% improvement in pain. Some studies did look at 50% improvement. I don't think that's sufficient enough because I think that's telling you there's still something else causing your symptoms in addition to the sacroiliac joint pain. So to really secure a diagnosis of just sacroiliac joint pain, I'm looking for 75, sometimes even 80% improvement. If you are going to proceed on to surgery, most surgeons are going to want 2 diagnostic tests, and this also applies for doing the ablation. Again, techniques you can use: fluoroscopic guidance, CT guidance. We use ultrasound guidance because it's easily accessible, it's affordable. We do it right there in the clinic on that day when we see the patient, versus sending someone to another provider to do a fluoroscopic guided or CT guided, which also induces radiation. However, the benefits to doing those two, the fluoroscopy or the CT, is that you can actually see the diagram of the dye going throughout the joint, whereas we can't see that on the ultrasound. We can just get a sense of, we see the needle going into the joint and we feel a release as we get through the joint capsule. Studies have actually shown, though, just doing a periarticular injection, meaning around the joint and not into the joint, are fairly sensitive, with only maybe a couple of percentages loss of sensitivity. So just differential, I've sort of touched on this throughout the whole time, but radiculopathy, so a pinched nerve in the back, typically you're looking at the L5, S1, or S2 nerves, as these cause pain in the buttocks, also going all the way down into the leg. Facet mediated pain typically is going to cause low back pain with many of the same exacerbating factors. So this can be a quite complex diagnosis to tease out. And again, often it's a combination of both. Not pictured, but spondylolysis is a fracture in the back of the pars. And this is similar to facet mediated pain, has similar exacerbating factors. Hip joint, as I said, can cause groin pain. Sacroiliac joint can cause groin pain. So looking at this as a culprit or another concomitant issue. Greater trochanteric pain syndrome, where patients have pain on the sides of their hip, usually from gluteal medial tendinopathy or tearing, but most often it's actually from an imbalance in the glute muscles, which can contribute to sacroiliac joint pain. So even though this is a differential diagnosis, I often see these combined. And then also trigger points. Any muscles in the low back or the buttock region can refer pain in similar patterns to the sacroiliac joint. Then things that you don't want to miss but are much less common: infection of the sacroiliac joint, a fracture of the sacrum or the ilium, malignancy, so metastatic disease to this area, or also any organ referral to this area. So this is just a generalized treatment. I'm going to go through things in a little bit more detail, but typically if you go to a doctor, you say, I have sacroiliac joint pain, this is what they're going to prescribe to you in a stepwise pattern. Often most people will start with oral medications, topical medications, then maybe get you into PT, some manual therapy, then injections, and possibly surgery. My approach for non-pregnancy, non-inflammatory treatment of SI joint pain is rehab. I explain to the patient that this is something that I don't recommend me giving you a home exercise program for. You should go in and see a physical therapist, sometimes one that specializes in pelvic floor muscles, sometimes just someone who's really good at the hip spine, because it's really hard to learn how to engage the right muscles at the right time. Often I'll ask someone to use their hip abductors, AB means go away, so that glute med muscle, and they're just going to use their hip flexors constantly, and that just keeps this issue going. So I'm a big proponent of getting them into rehab. I also talk about activity modification. This might be if they're a runner, backing off running while we're trying to work on these muscles being activated at the right time. I also might have them switch from a sitting position at work to a more standing position and alternating frequently, because again, most patients will have pain with any prolonged activity. I also talk about different sleep positions, such as sleeping on your side. Don't sleep on the affected side. Put a pillow between your legs. Then I might be using topical medications, because often they develop hypersensitivity in this area, myofascial pain. So I'll be having them rub maybe CBD cream or anti-inflammatory cream into this area using ice or heat. No great evidence for any of these. These are just things that clinically seem to work. And then again, given my background as an osteopath, I'm always thinking about someone, should they go to a manual therapist, maybe an osteopath, a chiropractor, and also acupuncture. I am most often recommending this. It's just depending on if their insurance covers it and based on the patient's time. Also, a lot of physical therapists are extremely skilled in doing manual therapy. So often I find it best if they can get everything at one place. I want them to do it there, because then they're more likely to keep up with it. So sacroiliac joint belt use, this can be a whole nother conversation. Some providers, including physicians and physical therapists, absolutely hate them. Some absolutely love them. I'm somewhere in between. I feel like the sacroiliac joint belt is great for someone when they have really bad pain, they can't tolerate a lot of activity, and I really want these people to get more active. So I will put them in the sacroiliac joint belt when they're doing activities that exacerbate their pain, but have them take it off for other parts of the day so that they're not weakening their muscles and they're engaging their muscles. I will also often use if someone's really hypermobile, but eventually we're going to be weaning from this. A lot of my patients who have sacroiliac joint belts that they wear to work, I have them actually only put on halfway through the day when their muscles are starting to fatigue. And eventually we might get to using them for 4 hours, then 3, 2, 1, and eventually not needing them once their muscles and ligaments are doing the work that they're supposed to be doing. Injections, again, I typically am using this more diagnostically, but we'll go over that I do tend to do some steroid and what are called platelet-rich plasma injections. And then I will typically, if they still have pain, get them into more rehab, maybe change up the location for a rehab, different perspective. Very rarely will I refer them for an ablation. I've yet to refer anyone for a sacroiliac joint fusion. I've had patients coming in to ask me about getting a fusion. I have told everyone you will get better if you just really work on your rehab. So if you guys got the main take-home point, rehab for this. And then my treatment for people with pregnancy-related SI joint pain. This is a little different in that we're typically not using medications. We're typically not using injections, although you can. I'm mostly talking to them about activity modification. So throughout their day, what are they doing that's exacerbating this? Really get them into a good rehab program. Most of the time I'm doing pelvic floor physical therapy, or again, someone who specializes in sacroiliac joint pain rehab. These patients I do tend to get in sacroiliac joint belts, especially people who are already hypermobile to begin with. But again, not encouraging them to wear all the time because I want their muscles to still do their job. And then I will often see them for manual therapy a few times, but really my job in manual therapy is to release restrictions. These people are typically more hypermobile. So what I'll do is show their partner. Usually I'll bring the partner in actually and show them different techniques that they can do to treat acute flares. And there's some really simple techniques that are very beneficial. Patients have found this really helpful because then they don't have to come into the office. They're already seeing physicians a lot, just monitoring during pregnancy. And acupuncture is also very safe during pregnancy. This can be used for a treatment of low back pain and any sleep-related issues related to the sacroiliac joint pain. So physical therapy goals, basically addressing any hypomobile segments, meaning in the lumbar spine or that sacroiliac joint or the hip joint. Also even looking at the foot. If the foot's off, it's going to throw off everything more proximally. Looking also for tight muscles and tendons, working on stretching those. Work on improving breathing. Any abnormalities in the diaphragm movement have actually been shown to correlate to sacroiliac joint dysfunction. So really making sure these people are taking an appropriate full breaths. And then that also helps with the pelvic floor motion. Address any strength deficits in the pelvic floor and the core and the hips. And then we work on progressing to neuromuscular control impairment. So this is activating the right muscle at the right time. So improving that brain to the muscle connection. Then the physical therapist will work with the patient on progressing to sport-specific activities and then learning and maintenance program for home, mostly a combination of flexibility, stability, and strengthening. And this is the most important for long-term management of sacroiliac joint pain. So manual therapy, again, this can be chiropractic, massage, acupuncture, and osteopath. And the goals, again, similar to physical therapy, relieve any restrictions in hypomobile segments, restore symmetry in the pelvis. Again, if there's a non-physiologic dysfunction of the sacrum, again, a posterior rotation of the sacrum, rather when it should be anterior when you're walking, treat that. Also work on decreasing the sympathetic tone, meaning sort of calm down those nerves that are sending those pain signals, and then improving blood flow and lymphatics to and from the region to help with improving health in the area. This is my standard approach to treating a patient with sacroiliac joint dysfunction. Again, it's going to be tailored to every single person, but this is generally when I'm looking at a patient. If I just have a couple of minutes in my appointment, I'm going to be looking for an abnormality in the pelvis. So those innominants that are rotated, look for lumbosacral hypomobility, sacral malalignment, any restrictions in the ligaments. I'm going to be doing some soft tissue to those areas, gluteal trigger points, and then also looking at the IT band. Often these become very tight. So working on relieving these restrictions so that the patient can then activate muscles better. Then we're also can stabilize from the outside. So I've already talked a little bit about the SI joint in my approach to using this, but kinesio tape can also be used. This is where the physical therapist teaches a patient how to put tape on the spine that helps with giving proprioception or feedback to the brain, and then also can help with stabilization. So what evidence actually exists for everything I just discussed? Unfortunately, very limited, and it's all based off of very poor studies. These studies are done with very small numbers. You can see up here, even one of them is listed as 7 subjects were studied. They're also mostly short term, so nothing's really looking beyond a year. Only very few studies have looked beyond a year. And a lot of the times, they can't tease out which modality or which treatment is most effective. And this is because it is probably a multifaceted approach. But it's just hard to compare, manual therapy versus stabilization, because you're usually actually recommending both of these because they both seem to make sense. So just looking at this in brief, I just wanted to show that, manual therapy plus physical therapy has actually been shown to change the alignment of the pelvis on radiographs in this small study, but it was shown, and it also changed the muscle activation patterns on EMG, electromyography. In 2019, there was a study done on 30 subjects looking at manual therapy versus stabilization exercises. Both were shown equally efficacious in improving pain, and also ODIs, the Oswestry Disability Index, so looking at function, and there was no difference between the two groups. In 2018, there was a study looking at acupuncture, manual therapy, and physical therapy, so a combined approach, which is my typical approach to the patient versus manual therapy alone versus physical therapy alone. And this in 81 subjects was shown that the combined group did better. This was seen at the 6-week mark, and they reported 78% improvement or treatment success. And there was another study in 2017. Basically, again, all of these were looking at different modalities, what can we use, and everything's always pretty much found effective. Manual therapy in this study was found to be slightly more effective than the other treatments. Okay, so what type of exercise should be prescribed? Well, I usually leave this up to the physical therapist, but my belief is that really focusing on the pelvic floor, as I said, the core muscles and the hip stabilizing muscles. Again, one of my favorite muscles is the gluteus medius muscle, as this gives lumbopelvic stability during single leg exercises. So this was a study done in 2010 on 15 subjects that were actually pain-free, so they did not have any sacroiliac joint pain or dysfunction. And they were looking at commonly prescribed exercises to see how well they activated the gluteus muscle, a medius muscle, and also their different subdivisions. So the gluteus medius muscle has an anterior, middle, and posterior aspect of it. And so in this study, the top left corner is looking at the wall press, and then the next picture down to the right is going to be your pelvic drop, and then the wall squat is the one in the bottom left corner. And it found that the wall press was the most, it was the best at activating all of the fibers, and also the best at activating the posterior fibers, which are thought to be most important in providing the lumbosacral and lumbopelvic stability. There's actually been one other study done that somewhat looked at this. My concerns with the study is it's a surface electrode, so you're not actually sure you're right over the muscle. There's also tensor fasciolata in the area, but I think this is a pretty good way of looking at, these different exercises and showing that we can activate different muscles in different positions. So I'm going to speed up. I just realized what time it was. But so for now, next is interventional injection options. You can use a steroid. Steroids tend to work pretty quick, but then we call them quick on, quick off. So they tend to work within about 2 weeks, but only last about 2 to 3 months. I often tell my patients that the pain doesn't come back. Usually the steroid is enough to decrease the pain to allow them to get more out of their physical therapy, to engage those muscles more without the pain inhibition, that then they don't usually need another injection. Every once in a while they might. The standard approach is no more than 3 steroid injections a year. My standard approach is no more than 1 a year, just because I don't think it's truly an inflammatory cause in most of the patients I'm seeing. Another treatment option is called platelet-rich plasma, or PRP. This is along more the regenerative line of treatment. It's not stem cells, but what it is it's your own body's quote unquote healing cells, the platelets. And we inject these into your sacroiliac joint or into the ligaments, and they bring in growth factors to the area to hopefully heal if there's ligament tears, but it also improves the health of the environment there to decrease pain. And so after a few weeks, it actually turns into an anti-inflammatory reaction and then causes a reduction in pain. These tend to take longer to work, so you're looking at about 4, maybe 6 weeks. But in other joints, such as the knee, they tend to last about 9 months to a year versus, again, the steroid is 2 to 3 months. There's also no harmful effects of it. Steroids, repeated steroids can accelerate arthritis in weight-bearing joints. Platelet-rich plasma has no harmful effects because it's your own body's cells. Prolotherapy is another thing where it's an injection of dextrose or sugar water, sterile sugar water, and it causes stimulates a healing response. So it actually initially causes irritation, but then causes a healing response. And prolotherapy can be used. It tends to require about 1 to 3 injections, more on the order of 3 injections every couple of weeks for its effects. Platelet-rich plasma and prolotherapy are both out-of-pocket expenses. So most of my patients, I am starting with a steroid, but then if their pain comes back, I'm talking about the other treatment options with them again. Radiofrequency ablation will go into more detail, but this is blocking the nerves. Okay, so is there any evidence for injections? Similar to the other studies, these are all done on small amount of subjects with short-term follow-up, usually only a few go long-term. So looking at this, NACE in 2016 was looking just at fluoroscopic guided intra-articular versus that periarticular, meaning the ligament steroid injection, and found both groups had immediate improvement in pain with no difference between the groups. So the thought is you don't actually even need to get it into the sacroiliac joint. You can probably just get it around the joint, and that should be sufficient enough. Then we're looking at Kim in 2010, looking at prolotherapy versus steroid injection. And this demonstrated significant improvement at the 2-week mark in both groups. But then in the long term, prolotherapy seems to be better, which makes sense, right? It's trying to create a stimulus or a healing response versus a steroid is just an acute anti-inflammatory. Then we're looking at steroid versus PRP. Singla et al. In 2017 found that PRP was superior to steroid at the 6-week mark and at the 3-month mark. And then looking at PRP versus prolotherapy, it's somewhat poor study, I would say, but they found that PRP was superior to prolotherapy at both 3 and 12 months and also required fewer injections. And you can see here the prolotherapy group required 3 injections, which is time consuming for a patient to come in. And there is also a risk of that reinjection of infection, although it's extremely low. So the radiofrequency ablation, when do you send a patient for this? I personally don't tend to need to send patients for this because they tend to get better with physical therapy and sometimes 1 or 2 injections. But the ablation is typically recommended when the patients have had pain more in the subacute to chronic time frame, and that they've had 2 positive diagnostic blocks, typically at 75% or more improvement in their pain for it to be covered by insurance. These can be done under fluoroscopic or CT guidance, again, targeting multiple branches of the nerves. These are all sensory nerves, nerves that send pain signals to the brain. They do not affect the function of the muscle. I do have a question if it affects the proprioception, or meaning the knowledge from the brain to the sacroiliac joint as to where that sacroiliac joint is in space. However, no studies have actually documented my concern is valid. So this is just still something I'm keeping an eye on in the literature to see if that ever comes out. But for right now, the radiofrequency ablation actually seems to be a very good approach for someone with chronic sacroiliac joint pain. These are just 2 studies I just put down here. Again, small studies. The first one was done 30 subjects in 2018, looking at radiofrequency ablation versus steroid. And at the 3 and 6 months, not surprisingly, radiofrequency ablation was found better than steroid. And that's because steroid tends to wear off at the 2 to 3 month mark. I didn't look into further detail, about if they do this in conjunction with physical therapy and all that. This was literally just looking at the injection options. There's a meta-analysis done with 15 randomized controlled trials in 2019. This is looking at chronic low back pain due to either facet arthritis or sacroiliac joint pain. And they found that the RFA appears to improve patients' functional outcomes when compared to non-surgical treatment options. And so they were comparing this more to actually sham injections, sham treatments, sometimes belts, sometimes physical therapy. Only 1 study went out to a year mark. And so I don't really feel like this is a great study because a lot of the patients, it takes months to do physical therapy and to really get better and to provide that stabilization. So of course, the radiofrequency ablation in the short term is going to do better. So next, surgery. This is a sore subject for me. As I said, I don't tend to send anyone for surgery for this, but I figured I had to do my due diligence and find what evidence actually exists for this. So who is a candidate? Most people are considered a candidate if they've had 6 months or more of low back pain. I would say this is failed treatment with conservative management for 6 months low back pain. This impairs daily activity, such as their work. Maybe they can't go for walks anymore. They can't sit for a while. And then they've also have 2 positive sacroiliac joint diagnostic tests. So there's 2 different procedures. In the past, the open sacroiliac joint fusion was always performed until the minimally invasive came out in 2009. These have been compared to each other. The open is found to have a much larger incision, so there's a higher risk for wound dehiscence, infection. There's also higher blood loss. These patients tend to stay in the hospital for more in the order of 3 to 4 days versus minimally invasive, maybe 1, maybe 2 days. They also have a prolonged period of non-weight bearing. These are really only now performed in the case of trauma, given the minimally invasive surgical procedures have so much lower risk of complications, and they also have a shorter return to activity. So typically these patients are on crutches with initially non-weight bearing and then restricted weight bearing for about 4 to 6 weeks. And typically they're returning to their normal activity around 6 months. This is just based on this iFuse system, the data they provide based on 45,000 procedures, which is actually a decent amount. So what actual evidence now exists for surgery? There's actually more articles than I put up here, but they're all very small studies except for a couple of them. And they're unfortunately looking more in the short term. Most are looking around 6 months to a year. Not many are going out a lot further, which I would like to know because I would like to know, are there complications from doing a fusion? So really these studies are good in showing that back pain improves, leg pain improves, function improves. But again, what's happening in the longer picture? Overall, most studies tend to show anywhere from about a 72 to 88% success rate, meaning significant improvement in pain and return to function. And relatively low complication seems to be about 2 to 3% complication. Often it's from a pinched nerve from the procedure. Sometimes it's from a wound infection or drainage from the site. But relatively low risk, especially given this minimally invasive requires a very small incision site. Okay, so what's the prognosis on sacroiliac joint pain? Unfortunately, we don't really have great evidence for this. Just in general, chronic low back pain, about 90% of people will have improvement, typically within about 6 months, max a year. And then those other 10% will typically go on to have chronic low back pain and some form of disability. There was a study done in 2004, that demonstrated that people who have a personalized stabilization exercise program, and they went to a physical therapist, got a home program dedicated to that person, will have 50% reduction in disability compared to someone who did not do that. So I really encourage patients to maintain the home exercises to prevent long-term complications or consequences of sacroiliac joint pain. In my practice, again, I tend to see people getting better with physical therapy and sometimes using an injection. Oftentimes, they just completely resolve their pain in around a year, but sometimes it's up to 2 years, which is very discouraging. But if they come in sooner, I think that would be shorter. The problem is people try to deal with this on their own. Then they might see a provider who doesn't think about the sacroiliac joint pain. So we're just I'm seeing patients who have already been dealing with this usually for a few years before they come to see me. If we don't get them into the right physical therapist too, then that also will prolong. So really someone who specializes in the sacroiliac joint, sometimes pelvic floor dysfunction, if they've already had, multiple children or they have hypermobility. So just getting them into the appropriate treatment from the start, I think will improve their prognosis. So basically, do we meet our objectives? So what I wanted to look at was the structure to understand pain generators. So thinking about the form and force closure, what provides that? So the actual structure of the sacroiliac joint itself, the ligaments are really important, and then the muscles around. Improving confidence and ability to make sacroiliac joint pain diagnosis. So again, you have to combine everything. You're combining the history, the physical exam, sometimes imaging and labs, and then usually relying on a sacroiliac joint diagnostic injection to confirm your suspicions. And then what evidence actually exists for treating sacroiliac joint pain? Unfortunately, the evidence we have is limited off of very small studies, short-term follow-ups. However, they do tend to favor doing manual therapy and stabilization exercises, and then sometimes the other modalities are important as well. It's most important to do a combined, multifaceted approach to treating these patients because, again, usually there's multiple issues causing the sacroiliac joint pain and sacroiliac joint dysfunction. And then surgery, it's always an option. Again, the studies that are available do show that it does have somewhat good outcomes. I just am still concerned about what's going to happen to the rest of the spine or the hips when you fuse an area. So my take-home points, choose a tailored treatment program for each of your patients. When you're doing your assessment, if you're a physician or a physical therapist, look for hyper or hypomobile segments of the sacroiliac joint or the spine. Look for any abnormalities in the diaphragm and breathing. Look for abnormalities in the pelvic floor, hip stabilizer muscles, and then look for those adjacent segment motion restrictions. And basically, then place your referral if you're a physician for physical therapy or manual therapy, because these are the ones that are shown to be the most effective in helping these patients. So thank you for the time and listening to this. And if you have any questions, I guess Kerri will probably help lead the next step, but this was just the other day out at Snoqualmie Pass with my dog playing in the snow. And then got a bunch of works cited, so I can always bring those up again.
Awesome. Thank you so much, Dr. Vernese. That was a really great presentation. So I know you have patients to get to in just a minute, so I don't want to take any more of your time.
I have a few minutes.
But I would,
yeah.
Okay.
Yeah.
So I guess it would be great. How can we pass patients off to you? Do you want us, should they email you, call you? How do they get a hold of you?
So for our practice, I work downtown at Cherry Hill on Tuesdays, which is downtown Seattle. And they can call our office. I can actually just give the number, I guess, right now, but it's 206-320-2600. You can also Google Swedish Cherry Hill Spine and Sport. And so you can call that office. You can also call our Bellevue office where I work on Monday, Wednesdays, and Fridays, and that's 425-498-2272. If you're a physical therapist, feel free to reach out to me directly to talk about patients. And that's how Kerri and we know each other, as we communicate on a lot of patients. And I think that's extremely helpful to help patients move forward, and patients really enjoy or appreciate knowing that they have a team working for them. So always feel free to reach out to me directly or through calling our office.
Perfect. Thank you so much. And then do you have time for one more question, or you got to get going here?
5, we're good. Yeah.
Okay. So I guess a question that I often get from patients is, what's the difference between going to see you versus going to see a traditional MD? And how should we decide, should we send a patient to an MD or somebody to, like you, a physiatrist?
I think that's a really good question. So just looking at the MDDO, feel like as an osteopath, we are really trained to look for asymmetries in mobility and asymmetries in structure and looking at the whole person. So looking, is there a foot restriction contributing to something more proximal like the hip or the shoulder or whatever? So I really feel like if it's a more complex diagnosis that might involve biomechanical issues, I think an osteopath is a great person. I will say though, most physiatrists, MD or DO, are equally trained in this. The only difference then is between the DO and the MD. The DOs are able to then perform the manual therapy so that we can already see, like in the clinic, will this patient respond to manual therapy? Because then it might tailor how to write our prescription for physical therapy. So right there in the clinic, you can actually get a treatment and see, is this going to help the pain? A lot of MDs now are getting training in osteopathic manual therapy. So actually one of my colleagues also does OMT despite being an MD, and he's really good at it. So I think the more and more people see benefit from the osteopathic approach, the more people are leaning towards doing that. So eventually I think there's probably not going to be a difference, but right now I would say that a lot of the DOs tend to be able to put that hands-on, do an adjustment, see if the patient responds to that to help better tailor a treatment approach.
Awesome. Thank you so much. Well, we won't take up any more of your time. Thank you so much for joining us, and thank you everybody for listening in and watching. We will be posting this onto YouTube. So if anybody wants to pass this video on to colleagues or patients, feel free to. And thank you again. This was a great talk.
Thank you. Thanks, Kerri.